Hi everyone. This week we're going to learn the basics about cancer disease management. Before we begin on learning that, we're going to have a quick review of some anatomy. Okay, if we keep in mind the basics of the body's tissue and anatomy, it will assist us in understanding the different types of cancers that we will be discussing over this semester. The body consists of four basic types of tissues: the epithelial, connective, muscle, and the nerve tissues. The epithelial tissue covers or lines surfaces, both inside and outside of the body. A basement membrane secures the epithelium to underlying connective tissue. Epithelial tissues have no blood vessels. This tissue may be a single layer or several cell layers thick. The epithelial tissue is classified into subtypes. The simple or epithelial membrane single layers of cells. Stratified is when membranes are several layers thick. Squamous is composed of thin, flat cells. The cuboidal are exactly what it sounds like, cube-like cells. The columnar, tall, column-like cells. And the goblet, those are cells that secrete mucus. There are different types of tumors and cancers that originate within the epithelial tissue. Cancers that are from an epithelial cell origin are called carcinomas. Cancers from the epithelial cells are squamous cell carcinomas. Cancers from the glandular cells are adenocarcinomas. When there is mixed features of glandular and squamous cell carcinomas, these are called transitional cell carcinomas. And then there are the benign tumors of glandular cells that we call adenomas. The second layer the second tissue is the connective tissue, which is the most abundant and most widely distributed of all the tissues. There are 5 subtypes of the connective tissues. The embryonal is found in the embryo and fetus. Vascular is found in the blood and lymph. Connective tissue binds skin to underlying organs, fills spaces between the muscles, and lies between the epithelium. Cartilage is the strong, smooth connective tissue that covers the bone ends at a joint. And then there's the bone, which is self-explanatory. Now, solid tumors of the connective tissue are called carcinomas. Of course, you'll find out that there are many exceptions when we talk about cancer information management. And in this case, the exception of lymphoma and leukemia sarcomas, which are quite rare, tend to spread by the hematologic routes and not through the connective tissue itself. Then we have the muscle tissue, which comprises of nearly 1/3 of our total body weight. There are 3 subtypes of muscle tissue. Oops, sorry, I slide in advance there. The first is the striated, the skeletal tissue that is attached to bones of the skeleton. And there's the smooth, the visceral tissue located in the hollow internal organs. And then the cardiac tissue that is only located in the walls of the heart. Then we have nerve tissues, which is found in the brain, spinal cord, and associated nerves. There are 2 subtypes which include the neurons or nerve cells and the neuroglial or glial cells. There are a variety of glial cells, which include astrocytes, which that's where you'll find the astrocytoma tumors, the oligodendrocytes, where you find the oligodendrogliomas. Then there's the microglia, and then the epidermal or epidermomas. That's not quite the easiest thing to say. So those are the different cancers and tumors that derive from these glial cells. Okay, so you can see how the name of the cancer is derived by the cell in which they originate. Now, tumor is a general term meaning swelling. A tumor is also known as a neoplasm. Okay, so a tumor or neoplasm, which you will find people, use one or the other. Sometimes they're talking about the same thing, sometimes they aren't. But a tumor or neoplasm can either be benign, which will not invade any other tissue or organs of the body, although it may grow in size and become quite large. A malignant tumor or neoplasm does invade adjacent tumors, tissues, and organs, and may metastasize or spread elsewhere in your body. Now, a diagnosis is the determination of the nature of a disease, and in our situation, it will be the diagnosis of the type of cancer that a patient has. All right? Cancer management is the complete process of the diagnosis, treatment, and follow-up of a person with cancer. Okay, and then there's the prognosis of the patient, which is the estimating or forecasting the probable outcome of their cancer or their survival of their cancer. In order to diagnose a patient with cancer, a biopsy, which is the surgical removal and examination of tissue to establish the mass or tumor, is truly a cancer. There are different types of biopsies, which include needle or core biopsy, needle aspiration, or sometimes called fine needle aspirate, or FNA, an incisional biopsy, which is just a piece of the tumor is cut out, but not the whole entire mass. Then there's an excisional biopsy, where they try to remove the entire mass or tumor. Then there's the punch biopsy, which is a special tool that is used to actually punch out a portion of the tumor. And this is usually used for skin cancer, and there's a little demonstration of how the punch biopsy works on your slide. So these are the most common types of biopsies that are used to diagnose cancer. When there is a microscopic examination by the pathologist of this biopsy, the morphologic examination of tissue is histology, all right? When there's morphologic examination of cells in fluids, washings, brushings, that is considered cytology, okay? So the histology is tissue, cytology is examinations of the cell. Most often, a diagnosis of cancer is used with histology, but there are some times that cytology is used. There are many different radiological methods that can be used and are used that diagnose cancer and to determine how far the cancer has spread. The most common methods are listed here on the slide. As we review the different cancer primary sites, you will get to know which methods are used for what site. Some are obvious. A mammogram is obviously used to diagnose a breast cancer. But there are some of these tests are used to diagnose a cancer or determine how far that cancer has spread. The major therapeutic cancer treatments are surgery, chemotherapy, radiation, hormone therapy, and immunotherapy. Okay, chemotherapy, hormone therapy, and immunotherapy are what is referred to as systemic therapy, which just means that the whole body is being treated or affected by that treatment. Surgery and radiation are considered local or regional therapy. They only affect that portion of the body in which they are targeted to. And then there's what we call multimodality therapy, which is any combination of more than one of the treatments that are listed on the slide. Most often today, most cancers are treated with multimodality therapy. All right, so keep in mind, these are the cancer treatments that we will be discussing when we learn about each individual cancer site. Now, treatment goals is to either cure the tumor, totally make it disappear, and totally be disease-free. Or sometimes the treatment goal is just to control that cancer, make sure that it doesn't spread any further, all right? And then sometimes the treatment goal is palliation, and that's just to relieve the symptoms of the disease to make the patient comfortable, okay? So just keep that in mind, that treatment isn't always a cure. Okay, depends on many different things on what that goal is, age, comorbidities, the extent of the cancer disease, and so forth. And we will discuss and determine when something is curative or palliative intent. Now, treatment is divided into two types. Okay, there's first course of treatment, which includes all cancer-directed therapy planned and given by the physician during or after the first diagnosis of a cancer. The planned treatment may include multi-modes of therapy, as we previously discussed, and may encompass intervals of a year or more, depending on the type of cancer and the type of treatment it is. Then there's subsequent treatment. That is all treatment following the discontinuation of first course of treatment. Okay, this includes therapies that are given after the completion of the first course treatment, or after therapy is discontinued due to treatment failure or cancer progression. Okay, so if someone's on therapy and the therapy fails, stops working, or the cancer becomes worse, okay, and then they change the treatment, that treatment in which they change to is subsequent treatment. It is no longer considered first course treatment. It is also considered subsequent treatment when a patient's cancer recurs and starts therapy again. Okay, so just keep in mind, first course treatment, subsequent treatment. Okay, so a patient that is diagnosed with breast cancer, they have surgery, they have their radiation, they complete hormone therapy, and 5 years later, they're disease-free, and then the next year, they end up recurring with their breast cancer, let's say to the bones, then they start treatment again. That would be subsequent treatment. Sometimes subsequent treatment can be soon after their first course treatment is over or years later. Now, some terminology that we'll need to know for when we discuss the different cancer sites. So Adjuvant therapy is prophylactic treatment given after surgical removal of the cancer. Okay? And it's given for potential microscopic spread of the cancer that may have been left behind at the time of the surgery, okay, in the hope of preventing or delaying that cancer from recurring or coming back. Adjuvant therapy is also given to prolong survival. There are some cancers that you will learn that if they are given adjuvant therapy, they will live longer than if they do not receive that therapy. Okay, now adjuvant therapy term is usually associated with chemotherapy, although radiation therapy is and can be adjuvant therapy in nature also. Now, neoadjuvant therapy is systemic and or radiation therapy given prior to surgical resection to reduce the bulk of locally advanced primary cancer, which is intended to make the tumor surgically resectable or to make this resection less extensive and to preserve the function of that organ. All right, so sometimes the tumor will be too large that if they resected it, they won't get good margins or they won't be able to take it all out surgically. So they give them chemo and or radiation therapy, get the tumor to shrink so that it's easier to remove the entire tumor cancer mass. Now, no treatment is a valid treatment choice, okay? And a physician and patient may decide not to start any treatment or therapy at the time of diagnosis for many reasons, okay? But they will continue to have active follow-up so that the treatment may be started at a later date if need be, okay? Now, this is considered or known as active surveillance or watchful waiting. This most often happens with prostate cancer and chronic lymphocytic leukemia or CLL. These are cancers that are sometimes asymptomatic and the patient doesn't need to start treatment right away. So they just follow closely with the physician, and then if they become symptomatic or the prostate cancer gets worse, where they can begin to have treatment then. Now, if this patient does start treatment at a later date, this treatment will be considered subsequent treatment since the no treatment is considered first course of treatment. So just remember that no treatment can and is considered first course of treatment. It's an active decision not to have any treatment for their cancer. Now, chemotherapy terminology that we'll need to know. There's treatment cycle, and that is one segment or dose of chemotherapy. A regimen consists of several cycles of chemotherapy. Now, induction chemotherapy is given initially to ablate or kill cells, usually leukemia, and achieve complete remission. All right. Then there's consolidation chemotherapy, and that's additional cycles given to eliminate undetected residual cells to prevent early relapse, okay? It is usually less intense and may be different chemotherapy than a patient received in induction therapy. Maintenance chemotherapy is prolonged administration of low-dose chemotherapy, usually 1 to 2 years in length. and this follows the completion of consolidation therapy. Okay, so just different terms that the induction, consolidation, and maintenance usually are with chemotherapy, but there are some maintenance chemotherapies that are used for different cancer sites, which we will discuss this semester. Now, in summary, keep the anatomy information handy that was in the beginning of this presentation, okay? Don't have to memorize it, but when we, discuss the different cancer sites, it will help you to understand, the different body anatomy and the types of cancers that are derived from those organs. Okay, so just keep it handy. You won't be tested on it, but just have it on hand. Okay. Make sure that you know the types of biopsies and the difference between histology and cytology. Now the different cancer treatments. Now the cancer treatments, there are some sites that will use all of those cancer treatments, okay? Or those cancer treatments can be options. But there are other cancer sites that some of those cancer treatments aren't options. And we'll discuss that, and you will see why some work for some sites and why they don't for others. Keep in mind what first course versus subsequent treatment is, okay? And then just know the difference between adjuvant versus neoadjuvant therapy, okay? There are some sites that you can have neoadjuvant therapy and are sometimes the standard of care, all right? And then also being able to define active surveillance or watchful waiting, which will be, we will discuss next week, because prostate is the first site that we will discuss, which is one of the sites that is very often does have active surveillance or watchful waiting. In fact, it's the urologist will, for most patients, that is an option unless they have an aggressive prostate cancer, okay? So make sure you keep those things handy and in mind. A lot of times that for the classes, students will ask me for study guides for the quizzes and exams. This is your study guide, okay? So if you know these things, you'll do fine for the quizzes and exams. Now, I know that was a lot of information, and sometimes you just have to go with the flow and say, yep, I need to know this information, and we will be applying that information throughout this semester, as well as the third and fourth semester, okay? So, but if you do have any questions or I confused you in something, please don't hesitate to post a question in the virtual office or the discussion board, okay? There is a short assignment for today's presentation, so make sure you hand that in by Sunday night, all right? And as I stated before, next week, we will learn about cancer management of prostate cancer. So I hope you guys have a great week. Talk to you soon.